do we have time for a question or? Okay, I think I do.
Right. So the next two presentations will be remote, and it is my great pleasure to introduce the next speaker, who is Carmen Scheibenbogen from the Charité in Berlin and the Institute of Medical Immunology at the same institution. And besides very prolific work in this area, she was in the forefront in building resources that are helpful for the entire community, namely a biobank and an infrastructure that may serve now clinical trials. So, Carmen, it is a great pleasure to listen to your talk.
Yes, thank you very much for the invitation. And I'm very sorry I cannot be with you today, as unfortunately there are two other conference presentations in Germany this week. So November is really the conference month. I hope you can see my slides now. And I'm going to talk about autoantibody treatments for an ECFS and long COVID. I will try to leave some minutes at the end for discussions. So to my background, I'm a clinical immunologist. So we do both taking care of patients with MECFS, but all the other forms of post-COVID and do research. And so I'm going to talk about evidence for autoantibodies we and other groups have so far, and the therapeutic trials which are ongoing to target autoimmunity. This is actually from a review we published within the Euroimmune group in
Carmen,
yeah?
May I suggest you press the slideshow button so that
okay.
we'll...
Yeah, so thanks.
Thank you.
Okay, yeah. And at that time, we had already evidence that immune dysregulation plays an important role, autonomous dysfunction, and also metabolic dysfunction. And fortunately, during the last years, we learned more details about these mechanisms. So we have good evidence now that autoantibodies do play a role in a subset, at least, of MECFS patients. I'm going to show some data on the G protein-coupled receptor antibodies and neuronal antibodies. We have good evidence for ongoing, at least low-level inflammation, heightened immune responses, and also neuroinflammation. As Saka just showed, we have evidence that there is association with EBV reactivation also in COVID. We have evidence for autonomous dysfunctions, typical sympathetic overactivity with vascular dysregulation, orthostatic intolerance, and microvascular hypoperfusion. And we have evidence for mitochondrial dysfunction resulting in impaired energy metabolism. And we also have quite good evidence now how this is linked, and we think that hypoperfusion is probably a central problem in the end, which can well explain many of the key symptoms, brain fog, fatigue, and also the post-exertional malaise. So what we've learned during the last 5 years about long COVID is that it's really a complex clinical picture, and also regarding the pathomechanisms. And we have a subset of long COVID patients that fulfill the diagnostic criteria for MECFS using the Canadian consensus criteria. These are approximately 10 to 20% that was shown in our cohort trial. We published already 2022 and in many others now. And we have many symptom overlaps also with long COVID. So also many long COVID patients suffer from severe fatigue and exertion intolerance, not fulfilling these criteria. We have also quite an overlap with pathomechanisms. We know that immune dysregulation, inflammation, mitochondrial dysfunction plays an important role in long COVID as well. I'm going to show you now some data about what we know about autoantibodies. And actually there is also quite an overlap in autoantibodies described in long COVID and ME/CFS patients. And this is the case for the antibodies against the so-called G protein-coupled receptor antibodies. A subset has elevated ANA antibodies correlating also with fatigue. And then there are several neuronal antibodies found in both groups. And we've also learned that COVID can trigger classical autoantibodies in a smaller subset. What we've also learned that there is evidence for molecular mimicry with EBV in the ME/CFS patients. I'm going to show you in a minute. I'm going to show you some data about antibodies to neural antigens, to G protein-coupled receptor antibodies. And what we've learned is that levels of several of these autoantibodies correlate with symptom severity and alterations in the central nervous system. So the G protein-coupled receptor antibodies are a very interesting family of regulatory antibodies. We find them in healthy people too. And what we've learned in post-COVID and ME/CFS that in a subset of patients, these antibodies are elevated, but more importantly, their levels correlate with symptom severity and also with ZNS alterations. And we at least know for the antibody to the beta-2 adrenergic receptor that the function is impaired in ME/CFS and post-COVID syndrome. These are the landmark studies from Japan showing that levels of beta-1 and beta-2 adrenergic receptor antibody correlate with changes in MRI studies. In the studies, these changes indicate a correlation with an altered pain response. And in the more recent studies, the changes indicate correlation of these antibodies with neuroinflammation. I also want to mention this study by the group from Ron Davis, in which they describe antibodies against myelin basic protein, which is the classical antigen in multiple sclerosis as well. And they found these antibodies in about half of the ME/CFS patients. And these antibodies, as shown here, have the special ability to digest the myelin basic protein and result in the demyelinization in multiple sclerosis. And there's some evidence that this in a milder form can also happen in ME/CFS. Now coming to our studies on the role of EBV as an antigenic target for autoantibodies in ME/CFS. And this is a study in Nuno Sepulveda had an important role. The first study we did is we looked against all proteins of EBV. We compared the antibody responses in patients against healthy control, and we found a signature that ME/CFS patients have more IgG responses to the EBNA6 protein. Then with the help of Nuno, we performed further bioinformatic analysis and found a very interesting region within EBNA6, which has such a polyadenine repeat sequence. And in these, we found higher antibody responses in the post-infectious ME/CFS subsets. And in a consecutive study, we then looked for human proteins with sequence similarities, and there are actually quite a lot having this polyarginine sequence, because this has several functions, for example, binding to DNA. So we selected a list of proteins where we see this mimicry, and again analyzed antibody responses against these proteins. And to summarize what we found is we found elevated antibodies against several of these proteins, including the alpha-adrenergic receptor, and here this is another interesting neuronal antigen, in multiple sclerosis through the SRRM3 and several others. And again, for several of these antibodies, we not only observed higher levels in the ME/CFS and post-COVID patients, but also correlations with symptom severity. So, of course, autoantibodies are no proof of causality. What provides us with evidence, or at least with more evidence, are IgG transfer models and, of course, autoantibody targeting in clinical trials. And fortunately, there were two IgG transfer studies performed last year, one in Akiko's group in Yale and the other in the group from Jerome Van Dannen in Amsterdam. And those could show that if you take the IgG from post-COVID patient, transfer it into mice, then several of the symptoms we know from post-COVID are induced in mice. For example, heightened pain response, as shown in this set of experiments, or that the muscle force, the grip strength is reduced, very similar to what we see in ME/CFS patients. And regarding clinical trials, there actually haven't been many clinical trials in ME/CFS during the last 2 decades, but there were these groundbreaking studies from the two Norwegians, Øystein Fluge and Olaf Meller. So they did a series of rituximab studies in ME/CFS. They could show efficacy and long-term clinical remission in a subset of patients. Unfortunately, the multi-center phase 3 trial failed to reach endpoint. Numerous causes have been discussed, and now there is now there is a study from Wakiro Sato in Tokyo, who is trying again rituximab in a phase 2 trial, and he is trying really to select the right patient. So we are hoping that he can confirm now that rituximab has efficacy in a subset of ME/CFS patients. And there were several groups, including ours, doing treatments with higher doses of IgG, which can also be effective in autoantibody-mediated disease. So this is the study we did with sub-Q intermediate dose IgG, and we gave it for 12 months. We included only patients with mild IgG or IgG subclass deficiencies to be within the indication, and what we observed is that the IgG not only led to reduced infection susceptibility, but also that patients improved. So this is the Child Fatigue Questionnaire. This is the SF36 functional score, and what we found is that from month 3 on, when the patient got the full dose, there was a significant improvement of the Child Fatigue and also the SF36 physical function. In a subgroup of 5 patients, we had a really clinical meaningful improvement with more than 25 points. However, we also observed that some patients do not tolerate it well. We had 4 patients who had to early discontinue treatment due to headaches, skin reaction, or liver toxicity or severe flu-like symptoms. Then there is a treatment by which you can reduce or diminish all antibodies with a device called immunoabsorption. This is a treatment which is well established in Germany for all autoantibody-mediated diseases. Usually it's a bridging therapy, is in a situation where you have rapid disease progress, or in a pregnant patient you cannot treat with medications. We did already 2 small trials pre-pandemic and got some evidence that in a subset of patients, the removal of IgG results in rapid symptom improvement. And then we got funding in 2022 from the government to do clinical trials in ME/CFS and post-COVID syndrome, and combine it with research. So we initiated 5 trials, 2 on immunoabsorption, and then the high-dose methylprednisolone to target inflammation, and 2 trials to target hypoperfusion. And just to show you the data for the immunoabsorption trial, so we included 20 patients who fulfilled MECFS criteria following COVID with elevated beta-2 adrenergic receptor antibodies with a BEL from 30 to 60, and they got 5 immunoabsorptions with Terasorb, which results in rapid depletion of IgG, as you see here. So the green period are the 5 days where they got the immunoabsorption procedure. And again, as very similar to what we saw with IgG therapy, we saw improvement of SF36 physical function. Before therapy, they were a little bit above 25, so they were housebound, and thereafter, in 14 patients, we had an increase in average to 60, which really means that they are back in life, although they still have symptoms, and that is not surprising because we do not get rid of the autoantibody-producing B cells, so we only reduce autoantibodies. We saw similar improvements in pain and also in markers of neurocognition. We did testing similar as Alsaka just described, and we also saw improvements in hand grip strength. And very importantly, we also find a marker, and we found a subset of B cells which was elevated pre-treatment in the majority of the post-COVID patients compared to healthy controls. And then when we looked after therapy, we see that these B cells dropped. So it looks as if immunoabsorption has also some effect on the B cell compartment. And most importantly, we could distinguish non-responder to immunoabsorption from responders. So it looks as if we have a marker to predict who will respond to autoantibody depleting therapies. At the moment, this is a highly sophisticated technique using CyTOF, but we are trying now to analyze this subset with a regular flow cytometry panel. So this would make it suitable to test patients in clinical trials very rapidly. And so that is what we plan now to do clinical trials targeting autoantibodies and plasma cells and using monoclonal antibodies against CD19, which also depletes plasmablasts. And we also want to use newer, more effective CD20 antibodies, which is the target of the rituximab as well. And we also prepare a trial targeting CD38, and you may have seen this remarkable study from Øystein Fluge and Olaf Meller again. They performed already a small 10-patient study with CD38 antibodies, and I show you one figure out of their study. What they showed is an impressive clinical response in 6 of 10 patients that they treated. Here again, you see the SF36 physical function, and you see a quite rapid improvement. And the patients, especially those who received 7 repetitive treatments, are back to normal. So 80 to 100 is the normal range of this measure in healthy people. And those not responding were those with the lowest NK cells. So this is probably one of the reasons patients not responding. The other, which is possible too, is that these are not autoantibody mediated at all. So this will also help if we are going to analyze the patients now with our B cell signature. And then, of course, this may open the door for many other therapies which are currently in development or are already licensed, which are much more specific, targeting certain pathways in B cell or T cell activations, and of course also have less toxicity. So to summarize, we do have evidence for a role of autoantibodies in long COVID and in ECFS. We do have evidence that autoantibody targeting therapies have efficacy in a subset, and it looks as if we have a specific B-cell signature which can predict a response. We have also by proteomics identified several soluble markers in which are characteristic for autoimmunity. So we think autoantibody targeting therapy holds great promise as effective treatment for the autoimmune subset of long COVID and ME/CFS, and this is to thank my wonderful team and all the supporters. And I want to invite you also to participate at our next conference on ME/CFS, which will be the 7th and 8th of May in Berlin, either on site or via live stream. So look, I'm happy to answer questions if there are any questions.
Thank you. Thank you very much, Carmen. I think that we have a joint session for questions, but I don't know if you will be online at that time and whether you prefer to have some questions now.
When will be the joint?
So the entire panel will have it is scheduled at 12 noon, so 1 p.m. Germany.
Also, sorry, 1 p.m. is too late for me.
Yes. So let's take a couple of questions. There is one over here, Miguel.
Okay, good morning. I'm Miguel Castelo Branco from the University of Coimbra. Thank you very much for your very nice talk. I have a couple of questions, very brief. First of all, I think it's very important that you talk about, first a comment. It's very important that you talk about subsets of patients, because it's clear to me that most trials fail because people tend to ignore in the design of the trials that they should target particular subsets. And that's why most of the trials fail to reach phase 3. This is just a comment, but now I come to questions. You talked a little bit about inflammation, like in the previous talk, and several of these autoantibodies make lesions to the endothelium. So my question to you is whether, I list the questions. So do you think that these endothelial disruptions can make these autoantibodies enter the central nervous system? In the previous talk, we heard a lot about brain fog. So that's the first question. Could be this a mechanism for entrance of antibodies in the brain? The second question relates to the therapies you have been discussing. It was very interesting, the one on the autoantibody against CD38, because in general, my feeling is that these treatments don't reach the long-lived cell niches. And so my question to you, which of these therapies do reach these niches, and how important it is to reach these niches? So I believe rituximab does not very effectively reach these niches.
So maybe I suggest to allow Claudia to answer these questions.
Yeah.
Carmen,
So
sorry, Carmen.
Answering your last question first is, we do not know yet which is the most effective autoantibody targeting therapy. The daratumumab antibody is quite effective. It has been developed for multiple myeloma and has been used actually in numerous other autoimmune diseases so far. There is another one from Sanofi, isatuximab. We are hopefully going to test in a trial too. And then, of course, there is CD19, which is very interesting too, because it's expressed on plasmablasts and on memory B cells, has less side effects on long-lived plasma cells. So I think we should test them all, and then if we find subsets where we have evidence for autoantibody-mediated disease, but these antibodies are not sufficiently effective, then we have several other opportunities. We do now have the B-specific antibodies targeting plasma cells and CD3 cells, which are more effective we know already in other autoimmune diseases. And then the final escalation would be CAR T cells, which are very, very effective to induce a deep depletion of plasma cells. But I don't think that we probably do not need these escalations. Regarding your questions, if these antibodies can go into the brain, theoretically, yes, if you have a disturbed blood-brain barrier, but there is no clear evidence yet. We did one study with Jonas Bergquist, and in this study we could at least not find these antibodies in the cerebrospinal fluid, which does not exclude that there are areas in the brain where they can bind. And the data from Japanese showing the correlations with findings in their MRI does not mean that these antibodies necessarily need to go into the brain. It can just mean that they bind in the periphery, for example, are related to pain responses, and that this results in changes in brain connectivities.
Thank you. Any more questions? Can I?
Okay.
No.
A very brief one. You talked about the B2 adrenergic autoantibody, but there are many other autoantibodies that can be elevated. So why the focus on these antibodies? So how strong is the evidence that this is the most pathogenic autoantibody?
So far, we only have correlation analysis. So we have correlations repeatedly found for fatigue, also for vascular symptoms. So patients frequently have symptoms of hypoperfusions in the extremities, for which we have a correlation with beta-2 adrenergic receptor antibodies. And then the Japanese studies I just showed. And then we analyzed in detail the function of the beta-2 adrenergic receptor antibodies. We know that they are functional. Healthy people too, they are agonistic, so they stimulate the receptor together with adrenaline, and in ME/CFS patient, the function of this antibody is impaired. So they cannot adequately stimulate beta-2 adrenergic receptor, and the beta-2 receptor is an important vasodilator in the microvasculature. So it would fit well to our concept that if this receptor is not properly working, you have a paradox vasoconstriction in your microvasculature upon exertion.
Thank you. No.
Hi, Carmen. It's Nuno here. Hello, how are you doing? I would always a very good overview of the autoimmunity hypothesis of ME/CFS. The only thing that I would like to ask you is that what's your perspective? What's the chronicity? How do you explain chronicity? Is it a lack of regulation of the immune system? Is it reactivation of the virus? Is it a bias on the B-cell repertoire or T-cell repertoire? What's your perspective on the, let's say, on the chronicity mechanisms?
Yeah, I think we most likely face circuits viciosus in the muscles and in the brain due to the hypoperfusion, because then the mitochondria get severely impaired and they produce oxygen radicals, and they trigger inflammation, of the small vessels. And that is what we also see in muscle biopsies. And I think that is probably situations a subset of patients cannot recover from. And that fits very well to the concept from Komarov too.
Thank you very much. Thank you, Carmen, for this remote participation.